So thank you and welcome everyone to our Research Connect series. My name is Heather Badnock and I'm a member of the CDTRP. I will be facilitating today's webinar. For those of us who haven't met, and it is so nice to see lots of familiar faces here, I'm a communication strategist based in Ottawa. I work only for nonprofit organizations, primarily in healthcare, social services, supportive affordable housing, and food security organizations. I'm also a non-directed living liver donor who gave in 2018. First, and very importantly, I would like to acknowledge that CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I am in Ottawa on unceded Algonquin Anishinaabe territory and encourage you to write your land acknowledgement in the chat box. We would also like to acknowledge Takeda and AstraZeneca, without whose generous support we could not host these sessions. The CDTRP also relies on the help of our community. Your gift ensures we can focus on delivering our mission of supporting excellence in donation and transplantation research. And there will be a link in the chat box for those who are interested. Now, before we dive into the main content, I have a CDTRP announcement to make, and this is a save the date for the annual scientific meeting. So crack out your calendar and block it off so that nobody books you, because you will not want to miss this year's annual scientific meeting. It'll be a hybrid format with the in-person component in Montreal, Quebec on, and this is to save the date, December 5th to 7th. The planning committee is currently working on a program that will interest individuals from all levels, people from all levels. Registration is expected to open in August. So don't lose your hats, because we will be in Montreal together before you know it. So before I introduce the speakers, a few housekeeping notes. Today's session is recorded and it's posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. And if you have any questions or comments, you can raise your hand with the raised hand button or type them in the comment section and we'll be keeping an eye. So I am pleased to introduce our presenter, Dr. Murdoch Leeies. Dr. Leeies is an organ donation, critical care medicine, and emergency medicine specialist physician based in Manitoba. He leads a collaborative program of research with a focus on promoting health equity in organ and tissue donation and transplantation. This intersectional research program pairs with his clinical work as an organ donation specialist physician with the Transplant Manitoba Gift of Life program. He extends his commitment to the principles of equity, diversity, and inclusion through academic and clinical services as the Director of EDI nationally for the Canadian Critical Care Society and the Chair and Co-Chair, respectively, of the EDI committees for critical care medicine and emergency medicine in Manitoba. So incredibly accomplished and engaged. He was recently awarded the Preparing for Research by Engaging Public and Patient Partners Award from the University of Manitoba Centre for Healthcare Innovation in support of the development of a 2S LGBTQIA+ patient and public advisory team, which will partner in the development of patient-centered research that explores the inequities that 2S LGBTQIA+ persons face in the Canadian organ and tissue donation and transplant system. Through this work, Dr. Leeies hopes to generate knowledge that can inform the reformation of structural and systemic elements of the healthcare system that uphold these inequities. We are all very excited, Dr. Leeies, and I will hand it over to you now.
Oh, fantastic. Well, thank you, Heather, for that introduction, and thanks so much, everybody, for having me here today. Just gonna switch to share my slides. And are you able to see those?
Yes, perfect.
Perfect. Okay, so I'll just say, as we're going through, I can't monitor the chat very well. If somebody has a pressing question, feel free to shout it out. But otherwise, we'll get started. And we're talking today about some issues in our system and some research that I've led on sociodemographic variable collection in organ and tissue donation and transplantation. Just to start off my talk, I'd like to acknowledge the territories where I'm based. And so I'm at the University of Manitoba. Our campuses are located on the the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories and acknowledge the harms and mistakes of the past. And we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So objectives for our talk today are to appreciate the benefits of enhanced collection of sociodemographic data in organ and tissue donation and transplantation, to learn best practices, relevant risks and benefits of enhanced sociodemographic variable collection, and to understand the current landscape regarding sociodemographic data collection in Canadian organ donation organizations. So a little bit of context and background before sharing any research results. Talking about collecting enhanced sociodemographic variables. Why is it needed, and what are the benefits in general of us having this information? And I would say at the very outset, adequate data is fundamental for us to understand what health inequities exist. And having that demographic data is also necessary for us to be able to effectively design and implement strategies to promote equity, diversity, decolonization, and inclusion in our system. So, we can't know what health inequities exist unless we have that data to inform us. And there's enthusiasm across lots of jurisdictions to improve health equity. Certainly people recognize, that helping everybody achieve the same, potential outcome is an important goal. But there's less consistency in the approaches used to measure inequalities in health and healthcare. And you all know, we have many health systems across Canada. They are, some of them very siloed, unique, variable in the amount of data and the different processes for data collection. So agreeing on and developing standards for kind of core data variables to measure inequities, as well as improving access to that data, would be a major benefit to enable comparisons across health systems or between health systems in different jurisdictions. So, there's a lot of literature supporting that social determinants of health result in differential outcomes for patients. I'm not going to spend any time reviewing that primary literature. I think that's been well established. And social determinants of health include different social identities that people hold. And these might be anything from your age to race to where you were born, the language you speak, et cetera, et cetera. And we know that in Canada, insufficiently granular data is a major limitation to us being able to better research and understand the equity landscape in healthcare. So the Canadian Institute of Health Information, they have developed pan-Canadian guidance on equity stratifiers, including which demographic variables to include, some considerations for how these should be defined and collected. And they've got ongoing work in this field. They're updating their sort of position statements and recommendations pretty regularly. They've paid attention to harmonizing data definitions so that we could compare and combine data between jurisdictions and collection processes of those data. And their approach aligns with Statistics Canada approach as well. So CIHI has this recommended minimum data set, and they recommend right here in the lower box on the slide that those variables be included. and collected in health systems across Canada. Sort of a global recommendation. These are not specific to organ donation, and I think there are some specific considerations that we need to make. And so we're going to talk more about that. And so at the outset of my research program, one of the first things we wanted to understand was the best way to collect this data. And, I was aware locally in Manitoba of some efforts a number of years ago to start collecting race and Indigenous identity. And that data collection failed. And I think it was now in retrospect with the work that we've done here, I think it was due to an insufficiently evidence-based implementation process. And so what we sought to do was a systematic review to understand what's been published about any best practices for sociodemographic variable collection, any risks to patients or providers, benefits of collecting this data, as well as any facilitators or barriers to help really inform a strategy of collection that is safe and effective and evidence-based. And so we conducted this systematic review and qualitative evidence synthesis. Now, one thing you may pick up here that you're thinking, what is, this is an emergency medicine. So equity relevant sociodemographic variable collection in emergency medicine, systematic review, qualitative evidence synthesis and recommendations for practice. So how does this relate to organ donation? Well, I can tell you, I work in all of these spaces. As we first planned this study and started doing some preliminary literature searches, I was cognizant of sort of looking to see where the literature was. And the emergency department interface is a major point where the majority of acute hospital admissions actually occur through emergency departments in Canada. And so this contact point is where a lot of our sociodemographic information is collected through the admissions process. Looking at other settings, critical care more generally, or organ donation, which is a very heterogeneous actually system. We've got living organ donors, deceased organ donors coming through different pathways. There really wasn't a lot of literature. And so we wanted to find some data and make sure it was meaningful. And so we focused in on the emergency department as our sort of point of contact. We included patients of any age, information about them, about substitute decision makers or caregivers in emergency medicine, healthcare workers or decision makers. And we were interested in studies or publications that talked about the routine collection of sociodemographics as a part of the medical record, either by survey or direct interview of patients. And the outcomes that we were interested in, I sort of mentioned already, were best practices for data collection or recommendations, any benefits, harms, facilitators, or barriers of routine collection. And so we sought to include clinical trials, observational studies, any guidelines, position statements, or consensus reports or innovation reports. We excluded for the systematic review non-peer-reviewed literature, non-English publications greater than 10 years old, news articles, and animal studies. And so this was a rigorously conducted systematic review. We developed a search strategy with an information specialist and a health librarian. We had that search strategy peer-reviewed by an external librarian through the press process, and ultimately searched the listed databases there: Medline, CINAHL, EBSCO, Cochrane Central, Embase, and Web of Science core database. And we also completed a gray literature search using the CADIF gray literature search tool. For anybody who's doing systematic reviews and doesn't know about this tool, it was relatively new to me during this review, and it's fantastic and it's free online. So I would highly recommend that if you're planning a gray literature search. And so here's our Prisma flow diagram for the systematic review. And so we identified 4,075 records. After our screening process, which was completed in duplicate, we ultimately included 21 studies in our review and all 21 studies as well in our evidence synthesis. And I'll just spend a minute talking about that qualitative evidence synthesis, because this is something that comes from the qualitative world. And so sometimes people in healthcare aren't as familiar with this methodology. And so the analysis that we conducted was a best fit framework synthesis with a paired inductive thematic analysis. And so really what this looked like was, after we included all of our studies and trials, we found, as we expected, that the majority of the literature was narrative or textual in nature. A lot of interviews, surveys of patients providing their perspectives about sociodemographic variable collection. So we uploaded all of the original text of all of the studies and coded all of the text. And so we took a deductive approach to start with. We had an a priori structured framework, and that was based around our objectives to identify best practices, benefits, harms, facilitators, benefits. So we looked for text and coded it according to that framework. But we anticipated that there might be additional themes that we hadn't included in the initial framework, and so we also performed a paired inductive thematic analysis to identify additional new themes or concepts. And I'll just share a lot of words on the screen. This is a word cloud that can serve sort of as an introduction to our results. So the word cloud is a method of visually representing text where the words that are most frequently used will appear larger and more centrally in our cloud. And so of all the words, all the codes that we made and identified in the text, you can see that patient is centered there. And this is a bit of a subjective experience for these word clouds, just to serve as a bit of an intro. So what did we find? We'll start with the benefits. As I mentioned already, we approached this research from the position of thinking that enhanced sociodemographic data would be a good thing, and that it would help us define inequities and be able to monitor interventions to resolve them. And so that really was one of the major benefits that was also supported in the literature, that this data offers the ability to quantify inequities and to design data-informed strategies to mitigate those inequities. But we found a number of other benefits, which I thought was quite fascinating. Just the act of collecting this data routinely combats systemic invisibility and underrepresentation. It reduces stigma through institutional recognition, and it can have benefits both for the individual who comes from an equity deserving group, but also for the larger population to normalize these equity deserving identities. Individuals described that seeing themselves represented on medical forms or from medical questionnaires, that this acknowledged the individual's inherent value and their lived experience. And then we also found people reporting that this act provided an ability to offer more holistic care for patients and more individualized care, because it allows the healthcare team to better understand the whole patient. And patients and healthcare workers also described enhanced therapeutic relationships with each other when enhanced sociodemographic variable collection was implemented. But there are some potential harms as well. And so some of the concerns or described harms from people who had experienced having this data collected was discrimination or stigmatization by healthcare workers following the disclosure, discrimination or stigmatization by others in the area, resulting from a privacy violation. Interestingly, healthcare workers were concerned about patient offense to being asked about different sociodemographics. Although I'll point out that when patients were surveyed, they said they would not be offended if they were asked these questions, but the healthcare worker perception was that they would be. So I think that was pretty interesting. Healthcare worker discomfort themselves about asking sensitive information. Patients were worried about experiencing worse clinical care due to unconscious or conscious biases of the healthcare team. There was a concern about exploitation of minority patients for teaching, and particularly most of the data in this regard came from transgender and gender diverse patients who felt that there were times when, once it was identified that they had a non-binary gender, that in a teaching center, they felt the sense of being used for teaching as opposed to being there to have their needs addressed, as well as unnecessary questions, testing or examination that aren't related to the complaint. Some potential harms there of disclosing different identities. And then talking a little bit about barriers and facilitators. So starting with barriers, some of the major barriers we identified were inadequate privacy. And this was the sort of single barrier that had the most evidence supporting it. Non-inclusive physical environments. Often we have very clinical spaces that we work in, and to have a space that doesn't offer any kind of ambassadorial symbols of inclusion can be, a little bit more daunting for somebody who's experienced discrimination or marginalization. And so just that small act of having things like a rainbow flag or an Indigenous medicine wheel, those symbols available can actually be a facilitator on the other side of the spectrum of patients feeling safe and being willing to disclose their identities. A lack of perceived benefits of disclosure or collection, so not really understanding why would I disclose this information, how will it help me or anybody. A lack of healthcare worker training in collection and cultural humility was identified as a barrier to implementation. Perception that patients would be offended if asked again, insufficient ownership and control of health information by the patients, as well as those fears of some of the harms mentioned, stigmatization, discrimination, or negative consequences of disclosure. Facilitators. On the other hand, we found that nonverbal collection methods facilitated disclosure, adequate privacy for disclosure. Importantly, standardized universal collection in so many of our health settings, particularly for identities where, I think we have a sense that there's a visual connection, so things like race. In many settings, people collect this data and put it into the health record based on visual estimation. You see somebody, they look like X, Y, or Z racial category, and you check that off in a box. Really, when you have a process that's standardized and universally applied, you're asking every person. You see a lot more of those benefits of normalization, et cetera, but it's also important for accurate variable collection because there are some identities that aren't easily visible and lots of assumptions that can be made. Having a welcoming or inclusive healthcare worker interaction prior to disclosure was a facilitator. You can imagine many busy emergency departments, hectic, not a fun place to be. And so there are a lot of negative interpersonal interactions that occur as a result of that. The presence of a population-specific advocacy service at that site was a facilitator, as well as having adequate healthcare worker training in cultural humility and sensitive demographic collection. So those were sort of our findings, the results of identifying these themes, and we made a series of recommendations that were synthesized based on our findings. So recommendations to implement a data collection process that optimizes patient safety, minimizes harms, and is also maximizes all of the facilitators and minimizes the barriers so that we can have an effective, accurate data collection process. So we recommended to use non-verbal collection methods for disclosure of sociodemographic variables, at least have these available. This was, I think, really driven by privacy, also perhaps some evidence about the potential discomfort that occurs with an interpersonal interaction. And so some people found it much less threatening to have a non-verbal option to be able to check off what they wanted and not have to, come out or disclose their identity to another person in the form of an interview. Provide private spaces for information sharing, irrespective of whether the disclosure is non-verbal or verbal. It doesn't help anybody to have a big, tablet that's visible to everybody in the audience when you're entering your information or in the waiting room. So privacy important. Format sociodemographic variable collection questions to facilitate self-identification. We're going to talk more about some evidence in the organ donation system to show how I think this could be improved. Structured data systems to incorporate ownership and control of personal health data. Develop standardized explanatory scripts to introduce sociodemographic variable collection. Make equity, diversity, and inclusion healthcare worker training mandatory and supported by institutional policies, and engineer processes that obviate the need for repetitive disclosure. It's been described as a harm as well when people have to deal with their identity, at registration and triage. Then they have to navigate it again when they get called into the room by the wrong honorific or pronoun. Then they've got to disclose it again to the first nurse who assesses, et cetera, et cetera. So when there are many points where repetitive disclosure is potentially going to be needed, thinking through that process to smooth it out can help prevent harm for patients. And this is just the final part of our recommendations. Give patients the opportunity to review or modify any retained sociodemographic information from previous visits or linked health records. So this is about providing ownership and control of this information. Enhance inclusivity through physical environments. So just circling back to that issue of how can we make our environments more welcoming? And small gestures can have a big impact. Develop population-specific support services. So many centers will have social work as a sort of general social service. Many centers have Indigenous health organizations, which are much needed and still under-resourced, but an amazing thing to be able to offer. And then there's a lot more variability in other support services, which we'll come back to as well. Create or revise and update existing institutional protections against discrimination. So having that hospital site policy that protects against discrimination was a facilitator of disclosure and safety. Implement reporting structures for patients. Interesting, some of the work that we've been doing has found that both staff and patients don't know how to report issues if they arise, instances of discrimination, of barriers to their care. And so implementing or improving existing reporting structures so that they're accessible is important. Facilitate engagement and measure institutional outcomes. And so, it's important not to just start this process and then leave it. We have to make sure that the data is being collected. It's happening in a safe and effective way, and allows us to continue sort of monitoring and auditing our performance through the system. And acknowledge harms for equity deserving populations and partner with them to reform structural inequities. So these were the synthesized recommendations from that review. And I'd like to talk a little bit about some more work we've done specific to the organ donation context. And I think you'll see that these principles really apply in both settings. Our implementation of processes for collection may be different because we've got different environments, different care providers collecting data in the organ donation system versus the emergency medicine registration and admissions system. But we'll dig into that. So this was another study that we just completed, and this is a survey of Canadian organ donation organizations looking at sociodemographic variables and what they collect and how they collect it. And so we just published this in Transplantation Direct. Our study, again, a little bit of background for this study. We've talked about why it's important for health systems to collect equity relevant sociodemographic variables. And so part of us understanding that work was to review the literature, but then also to conduct a bit of an environmental scan. What is the current landscape in Canada for this data collection? And so we undertook this National Health Information Survey of all Canadian ODOs. We wanted to find out the specific variables collected by each ODO across Canada and some of the definitions of variables and processes of collection, because these have not been defined in the literature in a summative fashion. And our hope was that these results would inform the development of a standard national data set of equity relevant sociodemographic variables. So we conducted the self-administered electronic cross-sectional closed survey. We distributed it to representatives from each of the 10 provincial ODOs that manage their data collection from start to finish. And survey domains that we employed included sociodemographics collected by the ODO, the variable definitions, so definitions of those demographics, which patient populations were represented. We'll show you some of the processes for collection, details on staff training, as well as any barriers or facilitators to the collection of equity-focused sociodemographics, as well as respondent impressions on feasibility of collection. And so just in brief here, these were the outcomes that we were looking to collect. Won't reread. And so we sent invitations to the 10 Canadian ODOs listed on the slide here, received 10 completed responses from each ODO, and analyzed all responses. Survey respondents were representatives of the ODOs across Canada. So this research project was conducted with the support and in partnership with Canadian Blood Services. And so these were all contacts known to Canadian Blood Services. They were ODO managers or ODO coordinators who would have the expertise and scope of practice required to be knowledgeable about their ODO's sociodemographic data collection. And people were encouraged, to seek out the appropriate information. We weren't looking for a time point response. If somebody didn't know something, we hoped they would try to find it out. And so our response completed our questionnaire in both English and French. This is a lot of text. Don't try to read all of this on the slide, but just showing you that we also included in the survey a glossary of relevant definitions for different social identities, different concepts for our respondents to ensure that everyone had a common understanding and a common language. So that was a part of our questionnaire. All right, so on to some results. We found in general that there was relatively sparse data collected on individuals registering their intention to donate organs. I think that comes as a surprise when you're registering your intention. We want to facilitate as many people registering as possible, and so want to make that process as smooth as possible. But understanding who's registering to donate the organs, then we're limited in our ability to do that. And so for donor card or electronic registry platforms, one service collected postal code, 2 primary residence, age in 2 programs, and gender in 1 program were the only variables listed as being collected. Additionally, only 3 out of 10 programs reported collecting any sociodemographic information on the substitute decision maker of potential deceased organ donors. And I'm not surprised by that finding either, but I think it is important to consider, especially for deceased organ donation, the person that we're interfacing with as a system is the substitute decision maker of our deceased donors, or for incapacitated donors who are being considered for that process in many cases. And so consideration for what relevant identities that caregiver has and is bringing to the interaction, I think is also needed. For deceased organ donors, some variables, things that are routinely collected already in the health system, like age and postal code, were pretty uniformly collected. For organ donors that are making it through the system to the point of data collection. No organ donation organizations collected any data on education, income, health insurance, or housing status. Although health insurance is maybe a little bit built into the system, and we assume that most Canadians have Canadian health insurance, but this was not specifically collected otherwise. Ability or disability was collected in 5 out of 10 programs in some fashion. And then we get into kind of 2 larger subject areas that sort of cluster together. So race, ethnicity, and Indigenous identity. Considering our collection of these variables, patient race was more commonly collected than ethnicity or indigeneity. And so I've got the numbers there for which programs collected each of those variables. 8 out of 10 collected race, 5 out of 10 ethnicity, and 4 out of 10 Indigenous identity. There was considerable variation in the modality by which these variables were collected. And so free text options, multiple choice, extraction from other parts of the health record were all described, with some programs using multiple modalities. Race and ethnicity, in terms of defining those variables and differentiating them, we found were poorly differentiated by programs. And typically there were multiple choice response options that included a combination of racial and ethnic identities. When collected, race, ethnicity, and indigeneity were collected mostly via multiple choice formats, with some being collected by free text. And no organ donation organizations used a distinctions-based response option for identification of indigeneity. And this is important, and I'm just going to spend a minute talking about it. So all programs who did collect indigeneity, which was 4 out of 10 programs, reported using a single summary identifier to capture all Indigenous people, a pan-Indigenous identifier. And that's what we do in Manitoba. We've got a document for collecting this data, and it has a checkbox with the word Aboriginal listed, and that's it. And so doing some more research right now using data from CIHI through the CORE database, Canadian Organ Replacement Register, I think it's called, our national sort of database, which we as provincial programs submit our data to. And so they similarly have a pan-Indigenous identifier. And so that's actually been a barrier for us being able to pursue any research that explores the impact of Indigenous identities through the organ donation journey, because they have this pan-Indigenous variable. The distinctions-based Indigenous organizations that we engage with to consult and to endorse research plans that include Indigenous identities don't approve typically use of pan-Indigenous identifiers. And so this is an important point for us to consider. If we want to use this data in any way to be able to help the people we're collecting it on, we're very limited in that right now. And so a distinctions-based approach where we identify First Nations, Inuit, and Métis at the very least identities as being distinct is preferred moving forward. Gender, sex, and sexual orientation related data was another area that clustered together. And so we found that sex was more commonly collected than gender. Not surprisingly, I think sex assigned at birth appears in the chart. So 9 out of 10 programs said they collected sex, 7 out of 10 programs said they collected gender. These were collected much more so than sexual orientation, with only 4 out of 10 programs saying that they collected that. Sex and gender were more commonly collected by multiple choice, and response options typically were dichotomized to male, female, or to add one other variable. So male, female unknown in 2 programs, or male, female other in 1 program. None of those being particularly inclusive. Response options for gender when collected by multiple choice, which was done in a minority of programs, but those who did provided their list. And so 1 program had a pretty good list of options: agender, bigender, cisgender, gender fluid, non-binary, transgender, two-spirit, and unknown. And the remaining 3 sites used male, female, or unknown other response options. Sexual orientation was reportedly collected via free text by 4 out of 10 programs, although 2 of those programs indicated that this variable came from the standard donor screening questionnaire, in which there are questions about sexual behaviors, but not sexual orientation. And so there may even have been some concerns about understanding of the difference between sex and gender, or sexual orientation and sexual behaviors on the part of our respondents. Data collectors. So organ donation organization coordinators collected most data from patients or from their substitute decision makers. A minority of data was collected from other allied healthcare staff. None was collected by physicians. 1 out of 10 programs reported an integrated data system where sociodemographic variables were sort of auto-populated from other parts of the medical record. And so that helps us identify who is doing the majority of the data collection if we're looking at enhancing that process. Other methods of variable collection, race, ethnicity, and indigeneity were collected by self-identification in a minority of programs overall, and or by data collector impression. Sex and gender were collected either indirectly from the medical record or referral form, most commonly, otherwise via self-identification. So that process of asking the patient, what is your identity, and having them tell you rather than assuming, or data collector impression. Sexual orientation was reported as collected by self-identification by all the programs who said they did collect this variable, which is good. Of the 4 programs who collected sexual orientation, 2 out of 4 specified that the variable came from the donation screening questionnaire, which again, doesn't actually ask about sexual orientation. So in terms of standardization and training of healthcare staff, it was uncommon for programs to endorse specific training for data collectors in how to collect sociodemographic variables in a culturally sensitive way. We had asked respondents about each identity and whether they had training. And so mostly 0 out of 10 programs had any specific training. Up to 2 out of 10 programs had some specific populations that they offered training for. Few programs similarly employed any kind of explanatory script explaining why sociodemographics were being collected and what this data would be used for, which was identified in our systematic review as being a facilitator of safe collection, some opportunity for improvement there. It was rare for programs to employ self-identification for disclosure via a structured interview, where interviewers read categories and response options from a list. So that process was more rare. Again, a little bit of a busy slide here, but just a list of some of the barriers to routine sociodemographic variable collection from the point of our respondents. And at the very top of this list, I think we could just kind of focus on that, is lack of cultural sensitivity training and lack of training in sociodemographic variable collection. Respondents were asked to rate each one of these if they felt it was a barrier, and so these numbers don't add up to 10. So each respondent could either rate or not list one of these as important. But so, you know, the largest majority of respondents felt that a lack of training was a barrier here. And competing priorities as well was a commonly endorsed barrier. In terms of facilitators, we asked about these facilitators, and people didn't kind of respond in exactly the opposite of their response to barriers, but 3 out of 10 felt that cultural sensitivity training would be a facilitator of routine sociodemographic variable collection. And 4 out of 10 felt that incorporation of patient advocacy services matched to the identity of that patient would benefit the ODO interaction. 3 out of 10, I thought interestingly also, programs felt that their staff, their ODO staff, were sufficiently diverse to represent the population that we serve. I don't know if that's true or not. My impression in general of critical care and organ donation is you know, that we've got some diversity, but diversity that I think is far below the population distributions of different identities. So further work probably needed to clarify whether that's true or not. Again, a busy slide. Don't look too closely at this. I'm just going to orient you. These were, our respondents were asked to rate the feasibility of sociodemographic variable collection for organ donors for each of the variables. So each bar here is a variable that you can see on the far right-hand side. And this is just a Likert scale, so graphically represented. If the majority is green and orange on the right-hand side of your screen, that's saying more feasible to collect, blue and yellow, less feasible. And so I think, not surprisingly, again, some of the variables that were felt to be feasible were things that we already collect because they're easy to collect: the age, sex, postal code, city, town. Other things that would require specific conversation or might be considered sensitive: religion, sexual orientation, a little bit less likely. And then some things like income, education were rated as not being very feasible to collect. Similarly, we asked respondents to comment on the feasibility of collecting sociodemographic data on the substitute decision makers. And so generally they felt that there was less feasibility to collect this data across all variables other than postal code and primary residence. So a little bit of a description of the landscape of data collection and organ donation organizations. So the take homes there, I would say, a minority of ODOs collect sufficient data to examine health inequities with an intersectional lens, certainly, considering that people have multiple identities that make up their individual identity. Most of the data collection occurs midway through the ODO interaction. So really at the point of consent is where most of our demographic data collection occurs, which limits our understanding about those who register and then subsequently decline to participate in donation or who might be ruled out very early in the process. Few programs collect demographics for substitute decision makers, which is relevant to deceased donation. And we identified some opportunities for improvement here. The variable definitions themselves were varied, and so those could be standardized and more clear. The use of self-identification as a process, opportunity to develop training for healthcare workers, both in sociodemographic variable collection, and I think in cultural humility in general, as well as the development of population-specific advocacy or support services. So next steps, designing a process for improvement. Just, recognizing again, now after we've seen a little bit of the organ donation landscape, talking about the commonalities between the emergency department, which inform the systematic review, versus some of the differences in our processes and data collection. So I think in common, in the emergency department, we see a diversity in severity of illness and emotional acuity of presentations. We have people presenting all the way from, critically ill being resuscitated actively to very minor. And so we deal with a wide range of emotional acuity, similar in deceased organ donation. Sometimes we're interfacing with families who are at peace. Sometimes they've just received the worst news of their life and they are in crisis. And so, that I think is common. Data collection, we collect data in both settings from both the patients themselves or from their caregivers. And so there's considerations, I think, from who we're collecting the data from that apply to both settings. Both settings have noted gaps in healthcare worker training. And in both settings, we've identified benefits of and requests actually from staff for standardized communication tools. And so a lot of similarities. There are some differences. I think time pressure, in emergency, there's a bit of a time pressure to get people registered and in, especially if they're unwell. And so that could hamper the process. My view of organ donation and deceased donation is that we've got a little bit more time to collect better data. Privacy, the emerges often registration and triage happen in a public waiting room. Often for deceased donation, we're able to, pull families aside into a private space to have a conversation. The data collector is different. It might be registration clerks or triage nurses in emerge. And it looks like in our donation system that the majority of data collection is done by our coordinators. So it might be a position with unique skills. I think our organ donation coordinators largely are highly skilled at engaging in sensitive conversations. So that's a major strength, I think, that we could leverage. And then there are multiple time points of interaction in organ donation, whereas in emergency, that data collection largely happens at one time point. There have been a couple of other review articles, none quite as in-depth as that systematic review that we put out, but some rapid reviews or reviews that focused on just a couple of variables. And there were no additional recommendations based on these reviews to conclude or consider. So right at the end here, next steps, deciding on a minimum equity relevant data set for inclusion. This work is ongoing, even in the organ donation space. There's a number of sort of different silos, I think, working on this right now, and maybe a bit of a lack of clarity also with some of our electronic health information systems. And some programs are about to switch systems. And so there's been a bit of, I think, delay to wanting to make major demographic variable collection changes until we understand what the capabilities of those electronic medical records are going to be, but establishing which health information system we use and what its capacities are. Two things that I'm working on as next steps now are to develop training for data collectors. So to develop specific curriculum for sociodemographic variable collection and cultural humility for organ transplantation donation staff. And then to implement this collection and evaluate the collector experience. So I think these are two next steps for me in my research program, although some of this other stuff will require logistical coordination. And then following up, we have to monitor the completeness of data collection and then commit to regular audits, evaluating diversity and outcomes in our patients. And if I have a minute, I did spend a little bit of time talking about this, but I'll just highlight again, talking about Indigenous identity data. CIHI has some recommendations for standards development and for community engagement that I support as well. I think they're recommending starting with literature review and engaging with individuals and groups from racialized and Indigenous communities, as well as stakeholders and experts. They followed this process to develop their standards. And so in May of 2020, they released their interim standards knowing that COVID was happening, and then updated these for race, ethnicity, and indigeneity data collection in July of 2020. And then again, March of 2022, they've just updated their standards based on engagement and feedback over the last 2 years. So again, at Transplant Manitoba, where I'm based in Manitoba, the variable that we capture for deceased donation is this single pan-Indigenous identifier. It's an outdated term, not consistent with best practices, and unfortunately, it is still the variable also used in our national databases, and it limits and prevents research. This is the CIHI recommended updated Indigenous identity standard. And so I've copied it from their report. The question asked is, do you identify as First Nations, Inuk, Inuit, and or Métis with the following response category options? So yes, to any of those, no, don't know, or prefer not to answer. It highlights here again as well that implementation of this data standard needs to include data governance agreements and have authentic and appropriate engagement with Indigenous groups. And then there are even, important sort of sub-levels of other Indigenous identities that could be relevant to healthcare and healthcare administration and delivery. So asking about registered or treaty Indian status based on the Indian Act of Canada, living on reserve or off reserve, some great research showing critical differences in health for on reserve and off reserve people. Are you a member of a First Nation or Indian band? Are you enrolled under the Inuit Land Claims Agreement for people who identify as Inuit? Or are you a registered member of a Métis organization or settlement if you're Métis? And so they provide some further guidance for any healthcare providers or authorities looking at expanding their Indigenous identity data collection. And so you could visit the CIHI website for that. I think we're coming up to the end of our time, so I won't spend too much more time talking about this, but would be happy to take any questions or comments.
Thank you so much, Dr. Leeies. As Linda said in the chat, excellent presentation, information, and insights. Thank you, Linda, for your comment. Does anybody have, we've got 4 minutes left, any questions? We've got one here that was sent directly. And Dr. Leeies, it says, what would you say to those who argue that our coordinators are burned out, overtasked, and that any additional work like this is simply too much given the limitations of the health system?
Thank you for that question. I think that's a common reaction that I'm receiving from lots of different levels when we're talking about expanding capacities of our health system. And certainly I recognize, COVID has been very damaging to our system. There is a lot of burnout and staffing issues. I think at times like this, it's more important than ever, though, to consider our most vulnerable populations, people who come from marginalized or oppressed populations. They are at even greater risk of experiencing harms in the health system than people who come from majority dominant identities. And so I think the need in a system like this is even greater. But I also think that some of those benefits described, normalizing people, enhancing therapeutic relationships, feeling like you're expanding your own skill set and doing something good, I think could be very protective for people who are feeling burned out. And I think that by actually implementing some of this, we might be able to help treat some of those symptoms. So I don't think it's necessarily a harm. And I think I see Dr. Weissler.
Thank you. Yeah, Matthew, you got a question?
Oh, thanks, Murdoch, for the great presentation. And I wanted to follow up on that last comment. And actually, something else you said during your presentation, I think is important too, is that if we were to have a system where you had a single collection point when the patient interacted, and that was transferable both within the hospital system, within the provincial system, within the ODO systems, it would really streamline things so that you wouldn't have a burden on, say, ER staff, ODO staff, et cetera, so and that would decrease the burden on the patient and the system, but it does take a lot of collaboration between multiple agencies and thinking that isn't just siloed into a single entity. So I just wanted to follow up on a point that I think would answer that other question as well.
Thank you.
Great point.
Yeah,
Katya,
definitely.
so you've got a question.
Oh, yes. Thank you so much. I typed it in. Thank you. I'm a postdoc from the MUHC. So I'm in research. So obviously we're super careful about describing how we're going to be using the information that we collect, as well as making very, very sure that we specify that it will be all de-identified. So this is interesting. I loved your presentation. How do you actually preface the collection of sociodemographic information in a clinical setting?
Yeah, that's a great question. Thank you. I think this is really interesting. And part of answering this question has to be considering what the current process is, which I think in most settings is considering that the person is implicitly consenting to disclosure of their information when they start sharing it, because we really don't have a standardized or ingrained consent process for that typically. So we just start asking people about their information, they start telling us, and we write it down. I think an effective explanatory statement needs to engage all of that. It has to be contextualized to the individual person who's delivering it. So it has to be appropriate for whoever's telling the patient about it. And I think decisions about keeping it concise, but with enough detail so the person is fully informed, are difficult. And it may vary also depending on the point at which it's collected and what kind of time pressures you have. And it may vary also, like thinking about, let's say, emergency departments coming in, wide range of acuity. There could be different processes, from the patient who is critically ill, there's only time to try to find out their identity so that we can get them into the system registered and, find critical information about them, versus somebody who might have time to be able to read through something themselves while they're waiting in the waiting room and enter. So I don't have a great answer because we haven't implemented this widespread. But I think in designing that statement, those considerations need to be included.
Thank you.
You had the final word there. So we are precisely 2:01. So thank you for the questions and comments. Dr. Leeies, on behalf of CDTRP, thank you for presenting. And if anyone has additional questions, comments, suggested topics and speakers, contact Erica Croft. So that's EKCROFT at cdtrp.ca. Stephanie has just very helpfully, as always, put it in the chat. So thank you, everyone, and enjoy the rest of your day.
Bye, everyone. Thank you.
Bye.